Good morning, everyone. My name is Ursula Chiswick. I am a pharmacist, and I will also be your instructor for today as I guide you through this unique continuing education program titled Educating Pharmacy Technicians for Success, Understanding Current Issues in Pediatric Medication Adherence. I hope that you will learn a great deal today and gain a new and inspired perspective about dealing with the pediatric population when it comes to taking medication. The more you learn and the more you know, the better prepared you will be to effectively counsel and interact with parents and children at the pharmacy counter. Let us begin. There are 8 main objectives I hope to accomplish by the end of this program. My hope is that you will understand the common barriers to medication adherence, that we discuss implications of poor medication adherence, that we go all the way back to the beginning and review the anatomy and physiology of taste, and most importantly, identify how taste can impact medication adherence. Then, of course, list common medications associated with poor palatability and considerations for flavoring medications in clinical practice. Finally, I will explain the importance of choice and patient preference with regards to medication adherence and highlight how flavoring can improve the medication experience and ultimately increase medication adherence. Adherence has become the preferred term over compliance, primarily because medication adherence implies a partnership, while medication compliance does not. Adherence suggests that individuals assume greater responsibility for and participation in decisions about their own health care. This is the essence of a clinician-patient partnership. The notion of compliance is an outdated concept and has been abandoned as a clinical practice goal in the medical management of patients and illness. It suggests that a person is passively following doctors' orders rather than actively collaborating in the treatment process. Medication adherence is the new buzzword in healthcare, and it is defined by the World Health Organization as the extent to which a person's behavior, taking medication, following a diet, and/or executing lifestyle changes, corresponds with agreed recommendations from a healthcare provider. The operative word being agreed. Adherence requires the individual's agreement to the recommendations for therapy. Former U.S. Surgeon General C. Everett Koop was quoted as saying, "Drugs don't work in patients who don't take them." It's one of my favorite quotes because it all boils down to such a simple concept. If a patient does not take their medication, for whatever reason, the medication will not work. And this becomes a major concern for many reasons. I'd like you to visualize something for a minute. I came up with the idea of an iceberg to represent the magnitude and depth of medication non-adherence. I'm sure that if I asked you, you can all quickly list the direct results of medication non-adherence, but there are so many indirect results of non-adherence that are equally damaging and should not be overlooked. That is why I chose to use the iceberg image to represent and acknowledge that some consequences are obvious and clear above the surface, while there is a greater impact that we don't necessarily or readily see below the surface. In addition to the reasons listed here, consider stress, addiction, superbugs, sleep disturbance, decline in social life, increasing health insurance premiums, and the list goes on. Many factors are involved in patient non-adherence. Factors related to the characteristics of the disease, medication side effects, duration of treatment, dosing frequency, complexity of treatment, and severity of the disease. Non-adherence can also take many different forms. The patient may simply fail to fill the prescription, or if the prescription is filled, The patient may incorrectly time the medication or take the wrong dose because he or she misunderstood or forgot the health professional's instructions. Patients may also forget a dose completely or prematurely terminate the medication. Moreover, sometimes patients may self-adjust their regimen because of side effects and toxicity or personal beliefs. But in today's program, we are focusing on the pediatric population. So what is it that makes children non-adherent? And what can we do as healthcare professionals to understand and address this demographic's specific needs? Let's take a look at the heart of the problem. Difficulty with pill swallowing is thought to be relatively common among children, and drug companies graciously try to accommodate this by offering liquid versions of common medications. While liquids are theoretically easier to administer, swallowing an unpleasant tasting liquid presents a whole new set of challenges. For the pediatric population, taste and poor palatability are identified among the most significant barriers to adherence. As a matter of fact, 79% of children complain medication tastes too yucky, and 70% of parents report struggling to administer a child's medication because of how it tastes. While it may seem the child is being difficult, this rejection is rarely due to the result of a child's desire to be picky or fussy. Rather, it is an actual physical inability to swallow an unpalatable substance. Scientists know that taste buds do wear out over time. As we get older, taste buds start to disappear from the sides and roof of the mouth. This results in duller taste sensations as we age. However, the scenario for infants and children is quite different. From birth, we start out with thousands of taste buds all over our mouths. As a result, flavors are much more intense for children than for adults. Childhood is often associated with periods of picky eating, but this can be attributed to the fact that their taste buds require less stimulation than those of adults. So some special considerations we must take into account is that children have a greater number of taste buds than adults. They are particularly sensitive to bitter and sweet tastes. And unfortunately, this becomes an issue since the active ingredient in many medications often tastes bitter. At this point, it would probably be helpful to review the anatomy and physiology of taste to better understand the biological basis for these underlying problems. Taste buds are located on the papillae of the tongue. The average adult has approximately 10,000 taste buds. Many taste buds lie along the walls of the papillae. Isolated ones are also present on the palate, the pharynx, and the epiglottis. Each taste bud is comprised of 50 to 150 taste receptor cells with taste nerves interwoven between. When taste cells are stimulated, the taste nerves depolarize and send taste signals to the brain, including the hypothalamus, the thalamus, and the gustatory part of the sensory cortex, or taste center, where these signals are then interpreted. The thalamus acts like a relay station, shunting the data onto appropriate cortical areas for processing. When combined with a sense of smell, flavor is perceived by the brain. Taste is a chemical sense, and flavor is the culmination of sight, taste, touch, and smell. Our senses of taste and smell give us great pleasure. Taste helps us enjoy food and beverages. Smell lets us enjoy the scents and fragrances of things like perfume or coffee. Taste and smell, however, also protect us, letting us know when food has gone bad or when there is a gas leak. Essentially, they are safety checkpoints prior to consumption. Almost all of us were taught in high school, and I believe it is still being taught these days, that our tongue has different regions, each corresponding and responding to a specific taste. This tongue map, as we refer to it, is a myth and totally inaccurate. Moreover, it is now agreed that there are 5 distinct tastes, 5 of which you definitely know: sweet, salty, sour, bitter, and the 5th known as umami, referring to a pleasant, savory taste. We used to think that variations in taste conform to a specific geographical pattern across the tongue, with sweet and salty tastes registering on the tip of the tongue, sour taking over along the sides, and bitter tastes isolated to the back of the tongue. Now we know that many areas of the mouth can record multiple tastes, although some taste receptors are better at distinguishing certain tastes than others. The 2 most relevant taste senses to our discussion today are sweet and bitter, as children are born with an evolutionary preference for sweet tastes and avoidance of bitter tastes. Sweet is significant because it provides a recognition of energy-rich foods and nutrients, things that our body craves or needs, while bitter allows sensing of diverse natural toxins, making our body respond in a negative way, warning us that we might be ingesting something potentially dangerous. In summary, the entire tongue can sense all of these tastes: sweet, salty, sour, bitter, and umami. The fact is that these regions do have variations in sensitivity to different tastes, but the variations are infinitesimal. What does vary by individual is the presence and density of taste buds. Individuals with a higher density of taste buds are referred to as supertasters and experience taste with far greater intensity than the average person. Evidence suggests that supertasters are more sensitive to bitter tastes and fattiness in foods and often show a lower acceptance of foods that are high in these taste qualities. Supertasters tend to dislike strong, bitter foods like raw broccoli, grapefruit juice, coffee, and dark chocolate. If you find that this resonates with you, perhaps you are one of the 25% of the population that falls into this category. Linda Bartoshuk, a professor with the University of Florida Center for Smell and Taste, and a pioneer in the study of supertasting, put it into a clever perspective when she said, "Supertasters live in a neon food world compared to the pastel food world everyone else lives in." Everyone else meaning 50% of the population that are normal tasters and 25% being non-tasters. Probably all of you have been non-tasters at some point in time. Even a simple cold, stuffy nose, or upper respiratory infection temporarily affects our ability to taste food as we normally do, rendering us non-tasters. Before we move on to the impact of taste on medication, I'd like to review. The basic senses of taste and smell are gatekeepers that decide what foreign substances are taken in or rejected by the body. As much as children are drawn to sweetness, they have an innate avoidance of bitter, and it is this predisposition to dislike bitter flavors that presents difficulties for children who must take oral medication. As I mentioned earlier, unfortunately, the active ingredient in many medications often tastes bitter and is accompanied by a pungent smell. Recent flavor research has focused on understanding the biology of bitter taste, and scientists are working to block bitter receptors so oral medications will taste better to children. This is especially important for children who suffer from chronic diseases and are taking not just one, but many medications a day. This becomes a big issue and a daily struggle for the child as well as the caregiver. Research supports taste as being a significant factor in medication adherence. After reviewing numerous relevant articles in this space, I wanted to share 4 important statements that resonated with me and I believe will help you better understand the framework surrounding pediatric medication non-adherence. 1. The number one reason for noncompliance among children when taking medicine or eating vegetables is that they don't like the taste. 2. The taste of an antibiotic is often not taken into account by practitioners, although there is significant evidence to show palatability correlates strongly with adherence. 3. A child often presents special challenges because the child is unaware of the purpose of the medication and is reluctant to take an unpleasant tasting tablet or syrup. 4. Prescribing should involve parents, children, and practitioners in an open discussion around the most suitable, palatable formulations for successful treatment outcomes. While drug companies recognize palatability issues with medication administration, often only one flavor per formulation is manufactured. This is primarily due to research and development costs, as well as production costs. Most mass-produced drugs often have only one or two readily available flavors that typically appeal to the majority of the population. But flavor preferences and aversions are highly individual. Although there are some genetic factors that cause differences in taste perception, similarities in taste preferences are much more commonly reflecting similar experiences with types of flavors and foods. That helps to explain the cross-cultural differences we see in taste preferences as well. Children in South America tend to prefer mango flavors, while children in the US prefer bubblegum flavors. It's what we grow up with, and it's what we know. These exposures and experiences help shape our preferences for taste. So having the ability to change the flavor of medication, to improve palatability, as well as meet a patient's preference for taste, can increase adherence and improve the overall patient experience. According to Julie Manella of Monell Chemical Senses Center, many parents are faced with the daily challenge of getting their children to take a medication. The unpleasant flavor of the medicine can thwart the benefits of even the most powerful drug, and failure to consume medication may do the child harm and in some cases may be life-threatening. Drug compliance in pediatrics is unique because compliance of the parent and the child must be taken into account, as parents are often responsible for giving the medication. It is important to take into account factors such as taste that may affect the ease with which parents are able to administer medications to their children. A more patient-centered approach involves effective communication and a partnership between the child, the parents, and the healthcare professional. Open discussions around issues such as taste, formulation, and dosing schedule can influence the selection of an appropriate medication and the success of the treatment. Medicine time is typically a stressful and unpleasant experience for parents and children. It is a vicious cycle that all begins with an unpleasant tasting medication and a hesitant child. Add to that a parent's frustration with administering a bad tasting medication, and very likely parents will stop treatment as soon as their child's symptoms go away, just to discontinue the struggle. Negative medication experiences can predispose children to believe that all medications, regardless of taste or smell, are unpleasant, giving them a negative impression of all medicinal treatments now and in the future. This is particularly problematic because medication adherence is such a huge and costly public health concern in our society today. I think that encouraging adherence in children in a positive way lays the foundation for positive adherence habits as they become adults. So how do parents and children cope with the stress of taking medication? Research shows that stress is the #1 health concern for Americans. Children are no different. According to Medline Plus Health Topics, Stress in Childhood, pain, injury, and illness are major stressors for children. Medical treatments produce even greater stress. It is no wonder sick children rebel, fight, and are upset about having to take medication. Being forced to take medicine when they're already sick simply compounds this stress and positions them on the defensive even more. To lessen the stress and anxiety of taking medications, parents have resorted to improving palatability through refrigeration or by mixing medications with milk, juice, soda, or syrup. Unfortunately, these home remedies can compromise the stability, efficacy, and potency of many liquid medications. A more feasible option is to have a liquid prescription flavored at a local pharmacy. Flavoring is a safe and effective solution that not only helps mask the unpleasant taste of a medication, but also customizes the medication to satisfy an individual child's taste preferences. Let's talk about the role of flavoring medications. Flavoring circumvents limitations in single flavoring options available, as we mentioned earlier, primarily due to production, research, and development costs. Flavoring provides choice to children in the flavor of their medication, even when they have no choice but to take their medication. Flavoring provides a method to ensure that first-line therapy is used, even when taste is a potential barrier. Flavoring offers an opportunity to improve adherence issues related to taste. And finally, flavoring provides individualization of care. To further highlight the role of flavoring medications, remember that manufactured medications do come pre-flavored, but taste is not one size fits all, and offering children a choice in a no-choice situation helps to reduce parent and caregiver stress. This has significant implications for clinical outcomes. Flavoring medication offers parents and prescribers the opportunity to incorporate the child and his or her taste preferences in taking medication. When the child's choice of flavor is incorporated, we see a reduction in parent and caregiver stress when administering the medication and a reduction in child stress when taking the medication. "60% of parents say medicine time with their kids is highly stressful. So offering mom and dad a solution to what is normally a high-stress situation elevates their pharmacy experience. And most importantly, flavoring leaves a lasting impression because it makes medicine time so much easier." To borrow from a concept mentioned in an earlier slide, let's explore the idea of offering children a choice in a no-choice situation. Involving the child in decision-making is referred to as shared decision-making. Shared decision-making in healthcare is a process of mutual partnership between the healthcare provider and the patient. Traditionally, children have had little involvement during their medical care visits or in decisions regarding their healthcare. Shared decision-making that strives to involve children enhances their self-confidence, encourages their cooperation, and improves their self-management skills. These are all key factors to medication adherence. So allowing children to choose how their medication will taste encourages a child to take charge of their own health and is yet another way to promote adherence. The addition of a safe pharmaceutical flavoring to medicine can greatly improve a child's sensation of taste and smell, leading to acceptance and therefore adherence. In fact, studies show that proper flavoring can increase adherence in children from 53% to over 90%. As a pharmacist or technician, simply recommend a product like FlavorX when dispensing a child's medication. The process is scientifically proven safe and effective. And unlike the addition of food or drink, FlavorX flavoring available at the pharmacy will not adversely affect a medicine's stability, efficacy, or potency. What do we need to take into account when opting to flavor? Patient age and taste preferences should be considered when choosing what flavor to add to medications. Younger patients are more likely to prefer sweeter flavors as compared to older patients. It is important to consider the type of medication to be flavored, as certain flavors may be better at masking bitter medications versus sour medications versus salty medications. We must also consider the traditional approaches to flavoring medications that have included the use of simple syrups, or sweet syrups, or even masking in fruit and chocolate flavored syrups. FlavorX is a commercially available flavoring system that is commonly used by retail and independent pharmacies in flavoring both compounded and manufactured medications. That is the product line I am most familiar with and will refer to as I discuss the concept of flavoring moving forward. Let's talk about medications that are known to be problematic. If I asked you, I'm sure that you could quickly name standout medications that come to mind when talking about poor taste or palatability. For instance, Augmentin, which is thick and chalky, ranitidine, which is strong and minty, ferrous sulfate or iron, which tastes and smells awful. In the next slide, I have included additional popularly dispensed medications that frequently present taste challenges for children. I'm sure that you will recognize many of the medications listed here. This list is not meant to be all-inclusive, simply a comprehensive list to make you understand just how problematic and widespread the issue of taste and palatability of liquid medications can actually be. The medications can be further broken down into subcategories, identifying why the medication is unpleasant. Is it bitter tasting? Is it foul tasting? Is it salty? Understanding the complaint or reason for the medication being unpleasant helps dictate which flavor masking agents would be most suitable and successful in masking the taste. FlavorX's extensive research and subsequent formulary development took these factors into account when making flavoring recommendations. Although patients are free to choose any preferred flavor, FlavorX research and experience has found that for medications that are bitter tasting, grape and bubblegum flavors seem most compatible. For foul tasting medications, the use of oil-based flavors such as lemon, orange, and raspberry produce the best result. For salty flavors, grape and raspberry appear to work the best. An important fact to mention is that FlavorX flavors work to modify the pre-existing flavor of a medication based on the active ingredient, regardless of the starting flavor. All of FlavorX's recipes for medications are formulated based on the active ingredients. Therefore, recipes for generic and brand name forms of medications are interchangeable. Now that I've convinced you that flavoring is a great option, let's focus on flavoring and what that means for your patient and your pharmacy. By flavoring, you are offering customization, you're allowing the patient to select their favorite flavor to create a lasting positive experience. By providing a choice of flavors no matter what medication is being dispensed, prescription or over-the-counter, you're providing excellent customer service and increasing the likelihood of higher prescription adherence. What could be better than that? Most parents and even many healthcare providers don't even know that flavoring is an option. Promoting the flavoring service to your customers can be fun and easy. You're providing a valuable service to parents who at the very least appreciate you giving them the option to have the medication custom flavored. We've heard from countless parents who say they love the service and are so thankful their pharmacy recommended it. The fact is, there are a whole bunch of moms and dads out there who want to know about custom flavoring for their child's medicine. So tell them about it. Let's shift gears. Now that we understand the history of taste, the present situation of pediatric non-adherence, and look toward the future. Research continues to identify factors that may assist in predicting taste preferences. Increasing our knowledge of individual variation in taste, due to both age and genetics, will shed light on potential strategies to stimulate a new era of drug formulations designed especially for the taste palate of children. Consideration should be given to the palatability and formulations of medications prescribed for young children. The use of simplified regimens of better tasting medications and age-appropriate delivery mechanisms enhances the ability of pediatric patients to adhere to their drug therapy, and that is the main goal. The issue of palatability with respect to pediatric medications has been recognized as an area for national and international focus. In 2002, a pediatric formulation initiative was established in the U.S., which focused on addressing the lack of appropriate medication formulations for children. Similarly, in Europe, the Pediatric Formulation Initiative aimed to expedite the development of better and safer medicines for children by identifying and scoping issues and challenges in pediatric formulation development. Both initiatives bring together members of academia, medical profession, the pharmaceutical industry, and regulatory agencies who then collaboratively tackle the development of age-appropriate formulations for pediatrics. Finally, some concluding thoughts and key takeaway messages to summarize what we have learned about the unique medication challenges faced in the pediatric age group. Medications successfully taken because of flavoring are far less physically, emotionally, and financially exhausting. For children, taste and choice may be the only motivation to take a medication and complete a full treatment program. Improving the taste of a medication and allowing patients to choose how their medication will taste can improve therapy adherence, leading to both improved clinical and economic outcomes. Finally, medication adherence is a major concern in the realm of healthcare, and now, I believe with this information, you have a solution. I'd like to share one final staggering statistic I think you should know about medication adherence in our country. Medication non-adherence in the U.S. costs up to $290 billion annually. The U.S. healthcare system could save hundreds of millions of dollars if medication adherence rates improved. If nothing else, I hope this program has taught you about the importance of focusing on medication adherence and offering adherence tools to your patients to help the individual, their family, and society as a whole. It has been my pleasure to teach you today. I hope you feel you have gained a better understanding of pediatric medication adherence. Should you have any questions, comments, or feedback, please feel free to contact me. Thank you again so much for your time, interest, and attention.